Good evening, everybody. It's almost 1 month since the last MDM. We didn't do because of our national conference. And today we are here again with 5 complex ILD cases. We will go one by one in each case. Experts for today, our radiologist is Bhavin sir, pathologist Ritu madam, and we have got with us Rajan sir, Prahlad Prabhu Desai sir from Mumbai, both from Mumbai, and Murli Mohan sir from Bangalore. And today, instead of Mithun, we have got Prithvi, who will be our rheumatologist expert today. So because we have 5 cases and usually we overshoot time, which Bhavin sir doesn't like. So we'll start immediately. And
There's a
my
Kailash Kher concert at 7, so we need to.
you are giving me time. So we have time till 7 o'clock, but I think we
No,
will
no,
wind
no.
up.
7 is the concert, so I need to leave the house.
Okay, yeah. So we need Bhavin sir to solve the cases. So we better be fast, and I will start sharing my screen. And first case is going to be presented by Dr. Mujib Rahman, who is a consultant pulmonologist in Lakeshore. And I'll just share my screen. So Mujib, all yours. You can start. Yeah.
Good evening, everybody. Nice to meet you all, and thank you for Dr. Ashmita, madam, and the team. First time I'm presenting here. I used to hear all your programs, but first time I'm presenting here. So my case is a 43-year-old female. She's a housewife, presented to my clinic with a progressive increasing cough and breathlessness for last 3 months. So the symptoms were progressive in nature for last 3 months, but for the last 2 weeks, the symptoms have aggravated more, and she presented to the hospital. This was only dry cough. There was no productive cough. It was also associated with fatigue and generalized weakness. There was no orthopnea, PND, or angina, no cardiac related symptoms, no edema all over the body or any pedal edema. There is no fever, weight loss, or hemoptysis. There is no arthralgia, muscle pain, or muscle weakness, or any skin rashes or skin tightening. There was no history of any redness of eye, dry eye, or dry mouth. There is no history of any significant or even no exposure to birds or industrial or chemical exposures. So, past history, there was nothing significant. She was perfectly all right. There was no comorbid illness, and there is no history of allergy, asthma, or any tuberculosis, no history of any rheumatology or pulmonary disease in the family. On examination, she was having hypoxia. The saturation at rest was 92% only, and she was tachycardic. Heart rate was 110, and there was no peripheral stigmata of any kind of rheumatological or any skin disease. The joints examination, skin examination, and even the muscle powers were normal. Chest examination, there was bilateral inspiratory crepitation, both in inframammary and inter and infrascapular area. There was a soft systolic murmur in the lower sternal border, and there was a loud P2. And we did initial X-ray and ECG and echocardiography, the first investigation in the OPD. The X-ray is in the next slide. So these were the X-ray, initial X-ray showing bilateral alveolar opacity, starting from the mid and lower zone, more denser in the lower zone area. And we did an echocardiography also. It was biventricular normal function, and there was moderate severe pulmonary hypertension. So this was the initial workup, and after the preliminary workup for the patient was admitted, we did the routine blood test and the rheumatological workup in considering the possibility of ILD with pulmonary hypertension. So RF factor anti-CCP was negative, ANA was positive with the homogeneous and 1:100 titer, and PNCA and CNCA was both negative, and there was elevated ESR of 80, but CRP was negative, and CPK was borderline moderately elevated. And we did a CT pulmonary angiogram with HRCT as the initial imaging. I think the image will be discussed. So the other routine blood test was also normal. The hemoglobin counts, eosinophils were normal. The liver function was normal. The tropi BNP was normal. The renal function and urine routine for this hematuria and proteinuria was normal.
Yeah, I think I will stop sharing. Other antibodies were also negative, and
Yes,
Bhavin sir can go. Meanwhile, Prithvi, you want to comment on ANA positivity and other things, you can go ahead and say.
Ma'am, regarding the ANA, it is like 1+ only, and it is homogeneous pattern. and the
Okay.
dilution is 1:100. So it is not significant. In this, only CPK levels are high that we
Yeah.
can discuss after that
Sure.
CT.
Sure. Okay.
So you all are able to see the images, right?
Yes, sir.
Yeah,
Yes.
absolutely.
So we have this first CT that was done in July. And if you look at the lung window images here, what we are basically seeing are areas of ground glass. Most of them have this peribronchovascular distribution. Some places you can see a little septal thickening. You could even say there's a little bit of crazy paving, but that's not that relevant. And it's a little lower zone predominance. I think, one of these areas, you can see this peribronchovascular really well here. Upper lobes are involved as well. And in the lower lobes, you can see a little denser appearance, almost tending towards consolidation. And most of it seems to be, symmetric bilaterally. There's absolutely no evidence of fibrosis. So this is a pattern that we would, I think, safely say is an organizing pneumonia pattern, with the understanding that vasculitis, IgG4 disease can all present as differentials of an OP pattern as well. I measured the MPA diameter on the right side. It's about 25 millimeters. So while it looks large, you're not really seeing evidence of pH. And the right ventricle wasn't larger than the left, but the right atrium was large. So if the echo shows pH, that would be fine. And then there's no significant lymphadenopathy. There's some prominence of the lymph nodes, but nothing more. So we're basically dealing with an organizing pneumonia pattern. So this is the first CT. I'll wait till the rest of the history to show the second CT.
Yeah. Sure.
So I have a patient with the interstitial pneumonia pattern, as discussed as a organized pneumonia, but I was not having any clinical evidence of any connective tissue disorder particularly, and with a very minimal positivity of NA as explained. So I have also sent the myositis profile, and it was showing a mild positivity in SRP antibody positive. And
One second, Prithvi, can you say this is significant?
Ma'am, it is only 1+, ma'am. Generally,
Okay.
SRP won't be presenting with this type of the clinical phenotype of the ILD. It can happen. Organizing pneumonia pattern can happen in this type of myositis with ILD, but ILD is less common with anti-SRP antibodies. Comparatively with the other phenotypes, MSI SRP is less common.
Okay, fine.
Yeah. So we have advised the patient to get a bronchoscopy and BAL, considering the diffuse parenchymal lung disease with organizing pneumonia pattern. But the patient was not keen to undergo a bronchoscopy procedure, and there was no protective sputum to do any microbiological investigation. So considering all these clinical and radiological evidence, they decided to start the treatment with a little bit higher dose on methylprednisolone. Considering the extensive involvement of the HSCT, we started on methylprednisolone 250 BD in initial 3 days. Then we tapered into 40 OD for another 4 days. The total 7 days patient was admitted. And we also started the patient on anti-PH medications because of the significant pulmonary hypertension. And over the 7 days, patient showed significant improvement. By the time day 7, the patient was about to discharge, the dyspnea was improved. And we did a repeat X-ray, but X-ray was not showing a significant improvement, but clinically she was better. And the subsequent follow-up X-rays and radiology was also showing serial improvement. We'll go into that later. And we tapered the steroid gradually over the next 2-3 months. And we also added a steroid sparing agent as azathioprine onto that. So these are the follow-up X-rays. Madam, please, can you? Okay, these are the on discharge. This is the first X-ray, and after the 2 weeks, there was significant improvement after the 2 weeks. And in the subsequent weeks and months also, there was significant improvement radiologically and clinically also. Patient's dyspnea, cough, both has improved. And by the end of 3 months, we repeated a HRCT, and we did a complete pulmonary and evaluation also. The pre-FT was nearly normal, FEC, FE1 ratios were relatively preserved. The DLCO, it was not available in my center, so but I have asked her to get it done at DLCO at least from other center. So that is work pending. And we did a 6-minute walk test. There was a desaturation up to 4%, and she could cover around 600 meter, and the dyspnea was after the exercise was mild. But surprisingly, the echo repeated at the end of 3 months showed improvement in pulmonary hypertension also. So this is the complete scenario, and the questions
I think we need to see the repeat CT scan also.
Yes, yes, yes.
Yeah.
Okay, okay.
Bhavin sir. You muted or?
Yeah, got it.
Hmm.
So, we can see two scans here. The one that I showed earlier was July. Now we have October. And as everyone can make out, there's significant improvement, some residual disease, but clearly the organizing pneumonia has significantly improved. So that's all there is to it.
Okay, now maybe we can go Murli sir and Prahlad sir, Prabhu sir, and
I think few things I would like to ask is that patient never had a history of fever, right, in the beginning.
No, sir, there was no fever, not in the
Was the
beginning.
patient having any tenderness on the muscles?
No, sir. Clinically, she was having generalized fatigue and just a little bit generalized weakness only, but there was no focal, any muscle tenderness. There was no difficulty in walking or climbing steps or not. There was no power was also well preserved, sir.
No, just academic point of view, just asking. Now, patient wants to know some diagnosis over here. Can Bhavin, being SRP being elevated and CPK being elevated, can this be some sort of an post-infective or inflammatory myositis? Can, in such condition, theoretically, a PET scan can guide us regarding the myositis and we can take a biopsy from that area? Will it be useful?
MRI would be better.
MRI better.
We do something called our MRI myositis protocol. So we look at the upper limbs, lower limbs, pelvic girdle. If we find edema and muscle involvement, then we can guide where the biopsy is to be done. Yes.
yeah.
So that will give the similar information like a lung biopsy, or it will be different?
I don't know.
Yeah. Okay. I think only Mohan sir. It's not there.
Now, how will we going for a steroid? Are we going to add any disease modifying agent? The reason is that the lung is not completely improved yet, anatomically at least.
So we have added azathioprine in the lower dose now towards the end of the 3rd month. Lower dose of steroid is now reduced to 8 mg now, and azathioprine is on board. But definitely she need a long-term follow-up. There was a lot of financial constraint for this patient, because that's why the MRI or other investigations were not done, and she was also not keen to undergo a bronchoscopy also initially. So we had managed based on the whatever by the end of the autoimmune workup and myositis workup, patient was financially bit low on the side to go for further workup in terms of radiology and intervention. So my point of was she was a middle-aged lady, but there was no clinical and clinical evidence that any particular connective tissue disorder. But only thing is the diffuse parenchymal lung disease with the organizing pneumonia pattern and little bit mild elevation of both ANA and SRK. So SRP. So I think it is a typical or atypical presentation. Anyway, it is not a typical presentation. I feel it is a typical presentation of anti-SRP myositis related ILD, probable. And how common is this entity is I have no much idea or no much experience. I haven't seen an anti-SRP myositis ILD before. This is my first time. I have seen other type of myositis ILD, but this is a first time I'm seeing anti-SRP positive, but that's also in lower titer. So in view of a lack of typical clinical signs and a lower titer of anti-SRP and lower titer of ANA, can it be an early presentation of myositis related ILD with a dissociation between the magnitude of lung involvement and the muscle involvement? That is my one thought. And second probability of a autoimmune, that is ILD with autoimmune feature at the moment, but it can turn into a classical myositis related ILD later, which need further follow-up. These were my thought process. I need to get the idea, the suggestion from the experts, and other treatment option also we need to discuss, and opinion from the experts are also invited regarding the BAL and the biopsy also.
Yeah, I think I have shared the question slides, Murli sir and Rajan sir, and now we have got Professor Wells also. But did you see the case, sir? Professor Wells, were you able to see?
I missed the first slide and would like to know the age and the severity and rapidity of progression, and that's all I need to know.
I will do that. I'll do
And
that.
then
No.
I've got quite
Yeah.
firm views on the case, which can actually wait for others to comment
Yeah.
if you. Yeah.
Yeah.
43, very
Female.
very severe presentation.
Yeah.
Couldn't do lung function.
This was her echo at the baseline, which was showing pulmonary hypertension, and then there was a CT scan.
Well, can you go back to the echo, please? Look, since
Yeah.
you've told me and I'll comment now, I was going to wait till the end. And I had 3 comments, but I was holding out for the age. So first of all, I strongly suspect that this is a form of inflammatory myopathy with ILD, looking at the age of the patient, the nature of the onset, and the absence of another classical ILD. Your only other option might be a form of cryptogenic organizing pneumonia, but it's quite an odd form. So you've got a CT phenotype with some bronchovascular emphasis, which we believe is a particular type in inflammatory myopathy. So you've got the presentation, and it's relatively acute progression. And then you come to the serology, and this is not serology picked up in a normal, it's serology with a very high pretest likelihood of a CTD. And then you get an autoantibody that we don't routinely measure very much. It's actually not on our list, and we're discovering more anti-synthetase associations all the time. So my first point is that I believe strongly, and I take the CK into account, and sure, there's not enough muscle injury or inflammation that you're being guided to a biopsy, but the CK on top of everything else, I think you're up at 90% territory. On the question of IPAF, that's not a diagnosis, but if you tick IPAF criteria, that's an excellent starting point for making a multidisciplinary diagnosis of CTD-ILD. IPAF's, of course, a research statement, and half the world calls it a diagnosis and half the world calls it a research statement. But I would urge stay away from IPAF diagnosis, but basically, it's yet another clue that in multidisciplinary discussion, you'll probably diagnose a CTD-ILD, as I think we can in this case. And lastly, can I see the echo report? Because quite commonly, when patients are very sick and they've progressed rapidly, you'll measure elevated pulmonary pressures. And what I really want to see is if the echo shows dilatation of right-sided structures. Now, if that's the case, then I think you know that the problem has been around for a while. It isn't just a consequence of a very sick patient who's too sick to do lung function, probably has been hypoxic recently, and lo and behold, once you deal with the ILD, the so-called pH, it vanishes. So I really would have wanted to know about the right-sided structures on that echo. As I say, if they're dilated, the pulmonary hypertension has been there for a while. And so it isn't just a consequence of this acute compromise. But all you've got on that report is elevated pressures. And I don't think inflammatory myopathy is on the list. Lupus and mixed connective tissue disease are, where you can actually reverse pulmonary hypertension with immunosuppression. I don't think that's true of inflammatory myopathy. So in summary, I'm arguing for a CTD-ILD inflammatory myopathy. There's enough elements, 3 domains are satisfied here: the clinical presentation, the scan, the serologies, plus CK. I wouldn't call it IPAF, and I doubt there was ever true pulmonary hypertension other than an acute manifestation of severe compromise.
Okay. Rajan sir and Murli sir, you want
Hi
to?
there, I'm Amila from Sri Lanka. Can I ask a
Yeah.
small question, please?
Yeah.
I'm just wondering actually whether this pulmonary hypertension, which could have been a manifestation of ILD itself, whether we should treat with vasodilators. I mean, because I feel that commencement of vasodilators at the initial point is a bit of a concerning, because this could have been a compensatory pulmonary hypertension rather than a pulmonary hypertension due to disease itself. Do you have any echoes repeated after the treatment, and have you continued the vasodilators or discontinued after the?
Yes, at the end of 3 months, along with the detailed pulmonary and radiological evaluation, and echo was repeated. The echo came as normal. The pulmonary hypertension has become normal, and now we have stopped the anti-PH medication. Now she's presently only on low-dose steroid with azathioprine at the moment.
Can you answer the question on dilatation of the right-sided structures on that first echo? It's absolutely crucial here, because you've got to expect you'll get elevated pressures with this sort of presentation. I see it time and again. You just put people on oxygen even, and the so-called pH vanishes.
So there was no dilatation, sir.
What is the answer on the echo? Because there will be a statement on dilatation of the right ventricle dysfunction, dilatation of the right atrium. And I think to call this true pH, that is what you need to see.
So
Okay.
even the echo
It is pH technically, but look, if somebody's very compromised, they've got sick quickly, they're hypoxic on minimal exertion, you tend to see elevated pressures in an echo.
So even if the echo didn't show it, the CT showed a normal RV, but an enlarged RA, which on the second scan has kind of reversed part. So,
That is fascinating.
Dr. Bhavin?
Because
Dr. Bhavin?
yeah.
No, I was asking Dr. Bhavin, what was the ratio of the pulmonary artery to aorta? Was it preserved? Because that's another indicator of.
But the ratio only works if the MPA is already dilated. If it's not dilated in a non-pediatric patient, then it doesn't matter. So you
So
have an MPA.
here it was not dilated.
No, the MPA was not dilated.
Yeah. So again, a point against, pH. And I'd urge you not to call it PAH, Dr. Mujibur. That's group 1 pH.
Yes.
Sure.
Yeah.
So if there is nothing more to be added, Rajan sir, you want to add something? Otherwise,
No, nothing. Only that I don't think I would have given sildenafil and ambrisentan.
Sure.
I think
That he has stopped.
Mujib, he would have settled without that probably. And ambrisentan I would certainly avoid, even if you suspected primary.
So one final question to the panel. Do we have a consensus diagnosis? Is it like what I understood is Athol sir told it is inflammatory myopathy related, and we are waiting for possible MRI thigh or something you can do to confirm the myopathy part and follow up the CK. And is it okay, Mujib? Are you happy?
I would agree with that. I think I would agree this is a myositis spectrum ILD. Even I don't go for MRI scan of the thigh and myositis because I think it's conclusive as Prof. said.
Sure. So we'll move on to the next
And
case.
one more.
Thank you. Yeah. Anybody want?
Ma'am, in that picture of labs, it is looking like inflammatory myopathy only, ma'am. We can see the ESR. ESR is very high and CRP is normal in this case.
Yeah,
Which can be seen in inflammatory myopathy.
Only myopathy. Yeah. Only. Yeah. So Mujib, thank you so much for presenting the case, and it was very interesting. We'll move on to the next case. Thank you. The second case here is from Dr. Tinku Joseph, who is from Amrita Hospital, Department of Pulmonary Medicine, and I will just share the screen. Yeah. Kunal,
Yes, ma'am, I'll be present. Yeah, so here we have a 20-year-old lady with no known comorbidities residing in Kerala. Could you go to the next? She presented to our emergency services with complaints of shortness of breath since 1 month, which was of grade 3 MMRC, and dry cough since 2 weeks. She was evaluated elsewhere for the same with a CT it showed bilateral ground glass opacities with mosaic attenuation. Sorry, I don't have the films with me, but they had done a bronchoscopy which shows suspicious milky bile fluid, and she was referred to us in view of possibility of pulmonary alveolar proteinosis.
Yeah.
And we admitted the patient, and this was the X-ray on presentation at our hospital. And we went ahead with the bronchoscopy, which revealed no inconclusive bowel reports, and the bowel was not milky. And
Yeah.
yeah, and then we went ahead with the
CT.
CT.
Yeah.
Yeah.
Before CT, I would like to ask what Ritu madam asked. Was she on any medicines and what was her BNP?
No. BNP was normal on presentation, and she was not on any medicine. She was just referred for evaluation of further suspicious of PAP.
Yeah. Bhavin sir, CT scan.
What were the echo findings?
Echo was normal, sir. We had done echo in our admission. It was normal. No pH. No pH.
We just have the CTPA here, but you can see the MPA again looks prominent, but the diameter is just 25 millimeters. RV is dilated compared to the RV-LV ratio is high. Then there are these bilateral pleural effusions. That's from this side. And then here you see a lot of this ground glass. But interestingly, there's extensive subpleural sparing. And when you get subpleural sparing like this, your thought is this some fluid containing situation in terms of edema, hemorrhage, any of those things that would occur here. Was there a drop of hemoglobin by any chance while being
No,
admitted?
sir.
No,
No,
none.
sir. There was no drop in hemoglobin, and clinically also there was no symptoms of.
And there's no septal thickening, which you would want if you had pulmonary alveolar proteinosis as a thought process. But for me, this is an edema pattern, or if you have clinical evidence, then acute lung injury pattern. And in fact, my initial thought when I looked at it was that this was a group 1 PH, where this patient probably had PCH, PVOD, or something like that, because you've got classic ground glass, you've got you've got evidence of PH, and you've got pleural effusions, but I could be wrong there as well. So basically, all we have is ground glass, subpleural sparing, some kind of an edema pattern, and pleural effusions and RV larger than LV, but with a normal MPA.
Yeah.
And share the screen.
So we went ahead with the connective tissue disease workup, which was negative, sir, and we have an ANA profile and myositis profile was also inconclusive. And then we proceeded with we had started her on steroids during this point of time, and then took her for a cryobiopsy upfront, and we took it from the left lower lobe, and these were the pathology findings.
Yeah, madam. Ritu madam. Sorry.
Ritu, you're muted.
Okay. Yeah. Can you hear me now?
Yeah, we can.
So I would say it's a very nice biopsy which is taken, good chunk of tissue which we have. If you look at the center of the biopsy, you can see that there is some amount of alveolar filling, and the peripheral spaces look normal. In this slide, they look the interstitium looks normal, but there is some amount of air trapping which can be seen. But what caught my attention in the left slide here, please, I'd like to go back to the first slide. What caught my attention in the first slide was that there are these two, just right off the bronchiole, there are these two vascular spaces which you can see. And next to the vascular spaces, that empty light area which is there, that is edema which is coming. So there is a lot of edema which is there in this perivascular region. So that's what got me thinking into this section. Then I looked at the next slide, and that's why I asked Madam if we could, enlarge the images. So if we look at the next slide, on the right-hand side, the image which is there on the right-hand side, I lost.
1 second.
Yeah. So the image which is there on the right-hand side, it's a very busy slide. There is a lot of interstitial inflammation, which is chronic. There are a lot of type 2 pneumocytes, which are, which can be seen with having the small round nucleus and the nucleolus and the cytoplasm and everything and all that. But what is there is something which is, really staring at us, and that is the foamy alveolar macrophages. And these foamy macrophages, if you can see on the right-hand side image, 1, 2, 3, 4, 5, 6. That's why I would like to zoom this right image here.
Let me see if I can zoom. I don't know how to do
So that
that
you can
in
see
the...
those finely vacuolated macrophages.
1 second. Huh? I will try to zoom if you want me to. This one, na?
Yeah. This one, the right side image. Yeah, just the right side image. So in all this busy slide, you can see this right bang in the center where the HNE 40X is written. Just above that to the right hand side, that's one foamy macrophage with cytoplasmic vacuolation, fine cytoplasmic vacuolation. There is one right, two right above it, two to the right of it. So there are at least in this small area, there are 5 of them. So that is what got me thinking into whether we're whether we're not just looking what are we dealing with here. Then I looked at the next slide. We could go to the next image. The next image is also has been focused on the pneumocytic hyperplasia and the air trapping and the inflammation and some amount of fibrosis, as we can see here. Whether now this is a fibroblastic foci as something that I like to look at under the microscope. And the next slide here is again showing. Now, if you look at the next slide here, it is one thing which you can see is that it's very pale. There is a lot of, it looks like it's edematous fluid, which is undergoing some kind of organization with some fibroblast creeping in. And to the left top corner, again, you see that that accumulation of this vacuolated cells which are here. So my immediate concern was about whether she was had any cardiac, issue, or whether we were dealing with, that kind of a problem because of these foamy vacuolated macrophages which were seen. So, and then the last slide again, the Mason's trichome you can see is not so. The dark blue here is the one which are the the fibers, collagen fibers which are there. But the maximum area is the spaces, and in the spaces the red color which is the RBCs and the accumulation of some fluid and fibrin which is there. So my diagnosis here would be of some kind of interstitial pneumonia, interstitial edema with vacuolated macrophages, whether they're lipoid in origin or some other storage disorder. I would like to look at that.
Oh, yeah. So we could have asked vaping history. Did you ask?
No, there was no vaping history.
Okay.
Patient is an engineering student, and the symptoms is not for 1 month. It's been there ongoing since 3 months. And one more question, ma'am. Can patient has been already been treated for steroids for close to like almost 2 weeks prior to biopsy? Can it also affect the interpretation?
No, the pathological changes are actually, I feel, long-standing. Because apart from the perivascular edema, the foamy macrophages, the the alveolar filling, a lot is going on actually. A lot is going on.
Because the pathology report which we got from our hospital is it's a kind of an organizing pneumonia with some amount of fibrosis. And this patient was treated subsequently again with steroids and then later on discharged. And the patient went to 3 other hospitals later on for second and third opinion, I would say. And the reports in the subsequent hospitals where it was reported as fibrosing NSIP.
Okay.
I
think our
rather,
panel.
I would rather put in a very, metabolic because she's young. And edema coming, I don't know whether it's cardiac in origin, I really don't know. But I would put fibrosis as secondary to whatever these primary changes are coming in drugs.
Yeah. I think we can take our experts' opinion, Prahlad sir and Rajan sir and Murli sir. Anybody wants to comment something?
I want to ask, the serological status was negative, no?
Negative, sir.
Yes, negative.
Rajan sir.
I I find those findings on the pathology not correlating with the short duration of symptoms. The symptoms 1 month and cough just from 2 weeks.
No, sir. It's for 3 months.
8 months.
3 months. 3 months.
3 months.
3 months. Okay. And do we have any lung function before this?
No, sir.
No,
We
we haven't done PFT.
Okay. And his echoes were normal?
Yes. Echo was normal.
Echo was normal. BNPs were also okay, you said, Kunal?
Yes, sir.
They were also okay.
Okay.
I don't know how I would treat this patient. I mean, I have it's really a tricky.
Yeah. Murli sir.
I would have brought this to MDD as well.
Okay. Murli sir, you want to say, or Atul Wells, Professor Wells?
Lipoid pneumonia is the possibility because of
So all I could say, sorry, Dr. Prabhudesh, I go
Yeah,
ahead.
you can go ahead.
Yeah. Yes, go ahead, sir.
I was frightened of commenting on this case, but then I've reached the conclusion if you've seen 3 glycogen storage patients, then you're an expert. And these are rare disorders. The first thing to say is when I've seen these present in the past, there has been information there's been a problem for a long time, but they appear to present more acutely, and one suspects that there's some sort of cofactor that triggers an acceleration of deposition. So I wouldn't be put off too much by the length of the history. The second thing is that if we're talking lipoid pneumonia, and I must say the pathology makes a very, very strong case, you probably, Bhavan's comments become crucial from what I've seen trying to get a sense of typical CT appearances. There is quite a spectrum. And I'm not sure this scan would be called classical for a lipoid process, but I don't either think that there's anything on the scan that makes me say the histopathology is wrong. But I'm really wanting to go back to Bhavan after I've stopped very shortly to make that point. Now, the next bit of this is, are we dealing with exogenous or endogenous lipoid deposition? And it's amazing how often when you then go back to the patient that you find they paint and suck the paintbrush, or they're using reflux treatment with lipoid material. And so that sort of process is worthwhile. I don't know what the various glycogen storage diseases, their prevalence in India, but I think you would be doing some of the tests that screen for these in this case. And when it comes to management, plainly, you are going to want to get the answer to that. Now,
in India, Pompe's disease is one which we commonly see, sir.
Right, and you probably therefore have a better sense of the CT spectrum than I do. I stress I'm going back to Bhavan on this to see if he's going to argue against this proposition on the CT appearances. And I think I'll stop because the management here, it's not a case where you would do whole lung lavage, I believe, but that would be an issue if it was more lipoid content. And other than that, the pharmacological therapies, I'm afraid, we really don't have anything we can rely on. But Bhavan, actually, your comment is probably more important.
The thing with all the infiltrative processes is that you should get septal thickening, and there is no septal thickening at all. And the more I'm looking at this, let me just share the thing again. So if you see the coronal images here, especially here, it's all peribronchovascular. You see this perivascular ground glass, and I missed it the first time, but perivascular invariably means that it is a vessel inflammation, as you might get with a vasculitis more than anything else. And the absence of, like I said, septal thickening should be profound in any condition that is either fluid or cells or lipids or anything that is infiltrative that we would get with either edema or any of these other conditions. So I am now wondering whether we're just dealing with a perivascular inflammatory process, in which case, I don't know if the pathology supports any of those conditions, and whether we're again looking at a capillaritis a process which presented acutely, and then we don't have a follow-up because this is in September, and I don't know if the patient has improved on treatment or not, and things like that.
So sorry to interrupt. So subsequently, patient was discharged from here, and then they went to tertiary care center in Chennai for further evaluation. And on the way, patient developed a pneumothorax, and then she was admitted at that particular center. And then after resolution of pneumothorax, they repeated a CT. It's been like almost 1 month after getting discharged from here. And the subsequent CT showed extensive fibrosis. The disease has significantly progressed with significant fibrosis, and she is currently on 6 liters of oxygen support and awaiting transplant, not responding to steroids.
That to me, it debunks the glycogen storage hypothesis. I had slight reservations, Bhavin, because we published in the Blue Journal a case of Niemann-Pick where you really didn't see the septal thickening, and we got a great response to whole lung lavage. But I think that obviously what you said made this much less likely. But progression to fibrosis over a very short time period really also adds to what you say, I think. You said vasculitis, and I would certainly take that aboard and do all of the systemic screening, urine microscopy, and chase signal. I think if you think it might be systemic, I wonder about a PET scan to try to tease this out. It's a weird vasculitis if it's a vasculitis, but vasculitides don't read medical textbooks at the best of times. So I think it's definitely there as a hypothesis. Otherwise, I guess you'd be thinking about some other form of autoimmunity that you just can't nail down.
Are there features, Ritu, of capillaritis or vasculitis on the biopsy?
Yeah, actually, there is a lot of very, vascular edema. So that is the main thing I can see at this power. That too in the larger ones, because I don't have a higher power of the section. So this was something which I got. But on this biopsy, the impression was that it was mainly perivascular edematous, less of fibrosis, and if it has progressed so rapidly, then the question would be what has caused it to progress so rapidly?
Yeah. Can it be some inhalation of some sort of a non-water soluble?
That's sir told, na? Reflux disease because of lipoid.
Oils,
So initially we considered the possibility of acute lung injury, and that was ruled out. There was no history like that.
But we have not ruled out glycogen storage disease, right?
No.
Yeah, we have to pass on that message to them, because then it is that if it is Pompe's disease, it is enzyme treatment. And I was just doing a quick search on the Google about Pompe's disease of CT findings, and it can cause the interstitial edema, capillaritis, and bilateral effusion, which was present in this patient also. So I believe that point has to be ruled out, definitely.
Absolutely.
I think the key there, though, is going to the follow-up scan and seeing whether the nature of progression on CT makes sense. And we've heard the scan now shows widespread fibrosis. And I suppose the word fibrosis covers a number of phenotypes, but I would have thought looking at the next scan, the scan that we haven't seen, I mean, might be very helpful.
Any family history, Kunal? Similar?
No, sir. No, ma'am. No family history.
Maybe they can come and see Sheila Nambudri madam because she is treating this kind of patients quite often with enzymatic treatment, and those patients are really doing well. So that will be worth.
Do they progress this fast, Asmita?
No, they do not, but we don't know, na, sir, because we don't have a diagnosis. That's why.
Yeah, but I think the lysosomal storage disorders don't progress like this. I mean, we've seen as Athol said, 3 cases make you an expert. So I have seen 3. Thank you so much. And
that way, I also have seen 3.
were Niemann-Picks, and we followed them, and they don't really. So, in fact, I'm giving a talk on Sunday on pediatric or child diseases.
Yeah,
And
mostly it is.
the one thing that I've realized is that they are non-fibrotic conditions. So this is more an inflammatory process that has acutely progressed to whatever they're calling as fibrosis. Remember that in COVID as well, everything within the first 1 month was called fibrosis simply because you saw traction bronchiectasis and volume loss. And when the patients improved, typically after 6 months, we saw everything rebounded. So in an acute situation, I'm very wary when people use the term fibrosis because it could be transient bronchial dilatation with volume loss that can come back to completely normal in an acute setting. So it would really help if we had those new images because it really makes a difference to know what the pattern is, and there are lots of things here like the subpleural sparing, which tells you that whatever it is, when you look at those inspiratory, expiratory pressures was staying out of the visceral and parietal pleura, yet you had effusion. All of that makes a difference. So maybe if we can see it the next time,
And Tinku, there in Chennai, they have obviously at an institute, if she is waitlisted for transplant, alveolar hemorrhage and that kind of thing, acutely presenting like this. If it's a vasculitis, then you
Go
could.
to the center, we can get the images, that's not a problem.
You could get those images, you think, Tinku?
Yes, sir. I can share the images with you.
There's one other thought just to place on the table. The foamy macrophages, now obviously this isn't amiodarone lung, but I would just raise that going back to the patient, just making sure there are no traditional therapies, but also looking at alternative therapies and just making sure this is not a form of, in inverted commas, drug-induced disease.
Yeah.
Actually, it probably won't be, but I think it would be a crime to miss that. That's all.
Even Ritu madam wanted me to find out the drugs, and also, yeah, the message is you rule out glycogen storage, rule out the alternative medicines are taken or not. Repeat imaging is must, and drugs which she has taken, we don't have a diagnosis.
Including inhaled drugs.
Case 3,
Sorry?
please.
It's not just inhaled drugs. I mean, orally taken drugs can produce an element of lipoid signal in drug-induced disease.
She was not on any regular medicines prior to this. She was absolutely fit and fine 3 months before.
So I would also ask about alternative things.
No, she was not on any alternative medicines.
Sure. But we can retake the history, no issues. I move on to the third case. We are running short of the time. Sure. So case 3 is from CMC Vellore, and Thomas will be presenting. Thomas, all yours.
Good evening, all. We have a case from Vellore, who is a 49-year-old gentleman from West Bengal, engineer by occupation, who presented with dry cough for the past 1 year, which was intermittent in nature, which was more nocturnal predominant and without any hemoptysis. He also had low back pain, which was of mechanical type for the past 5 years. There was no history of breathlessness. He did not have any symptoms of CPD or any other constitutional symptoms. He was a diabetic for the past 15 years. He was an active smoker with 18 pack years. There were no other exposures or no significant family history. He was a moderately built gentleman with a BMI of 20. Grade 3 clubbing was present on examination, but he said that he has noticed this from his childhood itself, the possibility of congenital challenge. And on auscultation, he had occasional fine inspiratory basilar crackles. He used a spirometry, so showing a
One
restrictive
second, one
pattern.
second, one second. Yeah, I'm sorry. I'll share again. I just muted, sir. That's it. Yeah, please.
Yes,
Go
ma'am.
ahead. Yeah.
Next slide, ma'am.
Yeah.
The spirometry was showing a restrictive pattern with 72% FVC and a reduced DLC of 57%, and lung volumes was 56% of total lung capacity without any air trapping, and the ANA was negative. So he is right now with us, and we wanted to ask the panel about radiological differentials.
Sure. Bhavin, sir.
Okay, so that's the CT, and if you look at the right side, that's the mediastinal stuff, and there's nothing there. So I'm just going to get rid of that and out of the picture for the time being. Now, if you look at the supine images here, if you start from the top, we're seeing all these cysts at the periphery, which now with the history of smoking would imply that there's substantial paraseptal emphysema. There is a little bit of centrilobular emphysema. A lot of these ill-defined areas of ground glass and reticular opacities at the periphery, which are predominantly centrilobular. And then as we get to the bottom, we find these areas of, reticular opacities and no subpleural sparing. There is some spatial and temporal homogeneity. And when I first saw the case without the history, my impression was that this fit a connective tissue disease, ILD. But in an active smoker, this is nothing but smoking-related lung disease, and there's a combination of findings. You have emphysema, there's respiratory bronchiolitis, and there is what we would just use the umbrella term SRIF or smoking-related interstitial fibrosis, because you're not able to otherwise characterize this, and this is currently not a UIP pattern. So if the patient doesn't have a defined, definite connective tissue disease, these are only smoking-related changes, and that's all there is to it.
Okay. I will just go to the questions. And Richa madam's, this is a case of Dr. Richa, so she also can whip in. One more look can be done for spirometry because sir is telling it is just smoking related. Okay. Yeah, Thomas.
Yes, sir. So CTD workup is awaited, sir. Extended ANA, although ANA is negative.
So these are the questions, and do you want me to put the slide and take questions or?
No, so number one, I can answer there are no differentials. Number two, yes, there is an ILD.
Okay.
Number four, I can answer, no, you don't need a cryobiopsy. So number three, now all the experts can look at.
Sure.
Sorry.
Yeah.
I was running out of time, so I was just saying.
Yeah, I know. We have to
This is an
finish.
18-pack years Bengali from Kolkata, I mean from West Bengal. That's what their lungs look like all the time. Yeah. So, I mean,
Okay.
in fact, look at the lungs even for lung nodules, for lung cancer and all of that, and none of that is there. So all good.
Richa madam, are you happy with the diagnosis? Then we can proceed. Yeah.
No, very quick one. Felt.
They told it's an NSIP on top of a CPFE. So that was the major issue.
So that was one of the,
CPFE. No. There's no.
CPFE, sir. Combined pulmonary fibrosis and emphysema. That was the.
CPFE is a phenotype. No, I mean, if you have emphysema and you have interstitial lung disease, you can turn around and say that that's a combined diagnosis. But I think Athol can say that you also need a clinical phenotype for CPFE where you have an emphysema predominant COPD with an interstitial fibrosis. So your what is it? Your FVC will be normal, look like, there are these parameters you need to look at. So any patient who has any emphysema and interstitial lung disease and a smoker could be called a CPFE. I'm a little wary about using the term so loosely every time. I would want a little more emphysema in this patient to call it CPFE. But if that's the issue, then I think Athol was in the guidelines committee and he can talk about this. So.
I hate the term CPFE. I mean, as a diagnosis, it's a bad term. And this patient doesn't fit it. And the reason I say that, your key point, Bhavin, was the FVC. And if you've got enough so-called CPFE to drag the FVC down, you ought to have a large gap between the FVC and the DLCO. But in fact, what you see is a classic ILD profile where the DLCO is just 10% lower than the FVC. The second point that interested me is that the so-called emphysema just seemed to co-segregate on CT, and I might be wrong, Bhavin, but it did seem as we went down the sections that the so-called emphysema, and I know he's a smoker, but it was curious how the cysts seemed to co-segregate on the scan with areas of ground glass, and I think that my suspicion might be that there's a bit of emphysematoid destruction as part of an interstitial process, but that's partly because I think this is an ILD, and I don't see any evidence of an impact functionally on what you would expect if there was true associated emphysema, and even your RV over TLC was normal. No obstruction in the presence of restriction. So I am wondering, it could be smoking related, driving a sort of NSIP process, but I would be very hesitant about putting emphysema into the diagnostic label. And I will repeat Bhavin's comment and mine. CPFE is not a diagnosis, it's an excuse.
So the
perhaps an apology.
So the only other issue is there is an element of respiratory bronchiolitis, and if you extend that to say that the ground glass, as Athol said, is a little more around the cystic areas than whether there is a DIP component, which is smoking related. So that's the spectrum. You can have, respiratory bronchiolitis a little more defined and it becomes a little more fuzzy and a little more areas, then you can call it DIP. But in the end, it's still the umbrella is smoking related lung disease, and smoking cessation pretty much takes care of 80 to 90% of these issues. I mean, correct me if I'm wrong. So that's all.
So what's the question? What's the question, Asmita, on this case?
The question is, in view of that reticulations in the lower lobes, should we consider it as a ILD itself?
Yes.
And if that we are considering it as an ILD, should we...
what is the treatment is the question. That is what, given the fact that symptoms are minimal, should they treat it? And should they do cryobiopsy?
Well, as Mita, just to say this, smoking-related ILD is fine as a term, but it's helpful to say it's SRILD RB predominant, SRILD DIP predominant, SRILD NSIP or UIP predominant, and that drives management. Now, in this case, my differential is going to be smoking driven, whatever this process is. I think the management depends how confidently on CT you can assign an ILD predominant category within the SRILD label. And Bhavin, I think you're hovering between RB and DIP by the sound of it.
I am. There is a little traction bronchiectasis in the lung bases, and you could argue that there could be an NSIP or a probable UIP component. But I think we should wait before doing anything. If the patient is able to stop smoking, and if we can repeat a scan at 6 months and check the PFT and all of that, we'll get a much better understanding of what the final status of the lungs is and then treat. I can, as a radiologist, I can put my foot down and say this patient doesn't need cryobiopsy for sure. And I don't think that at this stage any aggressive treatment is going to be an issue because we don't know what is the reversible component after smoking cessation and the irreversible component. And we need to tease that out first before we do anything else.
So right now we finally put it as an RB-ILD.
No, we just call it smoking-related spectrums, a spectrum of smoking-related lung diseases to be re-evaluated after the patient stops smoking.
I agree with that. And unfortunately, you would have to say SRILD, interstitial inflammation driven by smoking predominant, because actually placing this as DIP or RBILD, I don't think you can do that. What I do think is the emphysema you can see is the emphysema there is. Sometimes on a scan, you see some emphysema, but there's a lot more emphysema histologically. This is not such a case because you would definitely have a gap between volumes and gas transfer if it was. So don't overrate the amount of emphysema here.
But in case I would have liked to start treatment, what would it have been?
But I agree strongly with Bhavin, actually, because if the patient stops smoking and you start using steroid therapy, which is what you would do for a DIP, I mean, RBILD, it's very questionable wherever any treatment achieves anything. Then you get an improvement. You don't know if it's stopping smoking or whether it's the drug. So what do you then do with the drug? So I would say it's extremely logical to come back in 3 months and apply no labels. I mean, it's exactly what Bhavin said.
Yeah. Okay. I think you are happy with that, right, Thomas and Madam, Richa ma'am? Shall we just move on to the...
Can I just ask if an echo was done?
Echo was normal, sir.
I'm just asking because, so often you get pulmonary hypertension with the so-called CPFE, that it's worth looking at that also. But I'd agree. I think no treatment, encourage quit smoking, which is not easy, and review.
Okay, moving on to case 4, that is Ramnathan sir from Coimbatore case. Go ahead. Hello? Who is presenting Ramnathan? Ganesh, are you presenting Ramnathan sir's case?
Dr. Ramnathan is also there. You're on mute, Dr. Ramnathan.
Ramnathan sir is in some temple and Ganesh is not physically present.
You want to put up my case then, Asmita?
Yeah, we will go ahead with your case.
Quickly, I can just...
Yeah, I'll put your case and maybe Ramnathan sir can find out what happened to his PG. And I'll move to sir's case, Rajan sir's case, which is 5th case.
That 4th case is very straightforward. As in when it comes up, we'll just sort it out.
Sure. Sir.
So this lady, I saw her about a couple of weeks back. Never smoker and a cough that increased post-meal since 2019. Breathlessness with fast walks, stairs, dust, cooking, and a lot of asthma-like triggers as well, incense stick use. She also had a poor appetite for the last 2 years, no autoimmune symptoms. The rheumatology review by a rheumatologist in Mumbai, April 22, was negative. Bibasal crackles and grade 3 clubbing when I saw her. These were her bloods, ANA 1 in 160, fine speckled, P-ANCA weak positive 1 in 20, creatinine 1.25, no hypertension, no diabetes. And when we got her autoimmune workup, we got this Me2 positive. And she'd been already on nintedanib 150 twice a day and deflazacort 6 milligrams once a day for 2.5 years. And these were the lung functions I had with me. There was nothing before 2023, but we had a vital capacity that was at 1.49 and had dropped 100 ml this year when I saw her. a little before I saw her. DLCO is low. The KCO is what it is. And she's desaturating significantly on walking. The echo has an estimated pulmonary artery systolic pressure of 27, normal LV ejection fraction. And yeah, this was the ANA, the myositis. Yeah. Do we have a rheumatologist to comment on
Yeah. Prithvi, can you please comment on this?
Yeah, MI2 is significantly positive, but generally the baseline which we say is like MI2 is usually associated with decreased risk of ILD comparatively with the other things. MI2 have a decreased risk of ILD.
Okay.
But
So
this much strongly positive, you will consider positive, right, Prithvi?
Yeah, ma'am, it is positive. It is positive.
Yeah.
So that's, I got this workup done after seeing the scans, which Bhavin will go through.
Yeah.
So mediastinal windows, nothing contributory. So let me, get rid of them. And if you look at the lung windows, you start from the top, you can see some non-dependent involvement, some larger cysts, but there is honeycombing, reticular opacities, little bit of homogeneity. And then as we come down, you can see classic reticular opacities, traction bronchiectasis, and a whole lot of honeycombing. But the honeycombing is where you have large cysts, confluent, exuberance, all of that, some sharp margins here. If you were to look at let me see if I can get this down. If you can look at the coronals, then you can see the straight edge signs here. So we have a classic, we have a UIP pattern with, subpleural basal predominance, honeycombing, nothing else, all of that. But we also have findings that are highly suggestive of connective tissue disease, ILD, in the absence of smoking, because sometimes you can get exuberant honeycombing in smokers as well. And since she's not a smoker, I think for me, the big thing, even though she's 70 plus, you would want to rule out adult onset ILD, connective tissue disease.
Yeah, so with this autoantibody profile, I just wanted to know, I put her on mycophenolate, but would anyone here want to give her something stronger, considering she is fairly advanced in terms of her lung function, exercise, hypoxemia? That's my question, really. Prahlad, Murli,
I think
Athol.
considering her age at 70,
Yeah.
mycophenolate with the initial few days of corticosteroids, probably 3 weeks to 4 weeks.
She's on 6 mg
deflazacort
for the last 2.5 years, which is equivalent to 5 mg prednisolone. No?
Yeah, that will continue, and mycophenolate will be the drug, correct? I don't want to add more to that.
More aggressive treatment, you won't want to. Yeah.
I'd probably have a discussion with her, follow up over the next. She hasn't progressed very much since October of last year to now, or between the last two lung functions. I would agree, mycophenolate, keep a close eye on her, and turn, after discussion with her, decide if we want to be more aggressive if she starts to progress rapidly.
I have, yeah. So the rheumatologist, Murli, in April 22 said nothing active, but there was no myositis profile done, I think, at that time. Yeah. So I've asked her to review with him again, the same rheumatologist, and that's still pending. In the interim, does our rheumatologist have a view, or Athol?
Prithvi, you want to add
on? You go ahead, please. I've got something to say after this.
Yeah, Prithvi, go ahead.
Regarding the part, if you see the CT scan, there is more than 20% involvement of the, like comparatively, it was like severe form in the CT involvement. So better go ahead with higher form of immunosuppression with IV by like cyclo and all. In this case, we can give because there is a more risk of more involvement in these cases, and MI2 is strongly positive. And
instead of nintedanib, can we change it to tofacitinib or something like that, Prithvi? Because sir is asking about JAK2 inhibitor or something will help in fibrosis.
Why would you change nintedanib Asmita to tofacitinib?
no,
Nintedanib to
nintedanib is
continue. Now she's progressing for sure.
Okay, so you want to change MMF to something.
I'm just wondering something stronger than
Sure.
MMF, which Prithvi was suggesting cyclo. So
cyclo.
I'm
According to other studies and trials taken from the other diseases also, cyclo is best for the ILD, and if it is not MMF, then cyclo is the best for the ILD part.
it
And
will
no
act
other,
faster, yeah.
yeah,
And she seems in no hurry to do anything, but I think age is also there. But
yes.
since she came for a second opinion, and this was the workup, I was in a dilemma whether to give her something more aggressive or to stick with MMF, looking at her scan. Yeah.
Quality of life before all this happened.
Well, she has been declining the last, I think, the history, if you have that, Asmita, I think she's more challenged. If you take up the first slide,
Sure.
I think her symptoms had got a little, she had a cough that increases post-meal since 2000. There was no significant worsening of late. You know, this has been going on since 4 years, literally. I have a history with me also here. It's not that anything's got really much worse in terms of her life, though it is compromised.
Why should we add cyclona, sir? Because it comes with its own risk, right?
Yeah. And that's why
I don't want to write her off because she's 70. I mean, she could have a good 10, 15 years ahead of her. So, yeah, I think Dr. Paul wants to ask.
Please. Sir.
2 points, I think. The first is this is devastating, DLCO 22%.
Yeah.
And therefore, if I was going to make an error either way, the greater mistake is under treatment. You've got enough there to say this is driven by immune dysregulation. I realize, me too, that's actually unusual to get ILD with that antibody compared to some of the others, but nonetheless, it's strong. That's going to be the pathogenesis. DLCO 22, I would rather be accused of over-treating than under-treating from here. Any progression further will be absolutely devastating, and I don't see stuff that's reversible rather. So you're going to be treating to try to prevent progression. What might you use? The problem with cyclo is that you're really using that usually for rapid effect with reversible disease or in lung injury, and we're not seeing that here.
Yeah.
And we're talking about a long-term management.
Yeah.
And I have to say that cyclo is most alarming, actually, to use for the long term. So I would be saying that if you did anything more, you applied the EVER-ILD trial and you considered adding rituximab to mycophenolate. Now, the bit about this that is really unusual, I think, is the lung function profile. There are 3 reasons that you can get this sort of gap between DLCO of 22% and an FVC of 68%. The first is pulmonary hypertension, but you've actually ruled that out. And what's more, you've not got cardiac disease driving pH. The ejection fraction was 60%. The second reason is your ILD is very fine diffuse ground glass, knocking the gas transfer, but not the volumes. That is definitely not the case here. It's a CPFE picture, and then you've got these large cysts, which we're calling honeycombing, but it's in the ILD, but it's almost like somehow the morphology's given you a CPFE profile. Now, I just raise this to make the point it's weird, and I don't really understand it. And I'll come back to management. I would rather over-treat than under-treat.
Okay.
And so you would say to consider rituximab?
Yeah, I'm just throwing that out for other people to comment on. There will be rheumatologists here who might say that's not a good idea, but I'm not sure I like cyclophosphamide here because you're looking for a long-term approach here.
Sure.
But I think Dr. Asmita's suggestion of tofacitinib is not a bad idea. It's pretty well tolerated. Don't know how well it's going to work. And
Which one? Sorry?
Tofacitinib.
JAK2 inhibitor.
JAK2.
Yeah, I think very reasonable. And another one you could consider is tacrolimus, which you can use in combination and which has had results in inflammatory myopathy, ILD. I mean, this is where actually I would keep my mouth shut and get a rheumatologist to make the final decision.
Yeah.
But I would be saying to the rheumatologist, we got to add something else.
I'm waiting for her rheumatology review in Mumbai as well. And
Yeah.
I realized that there's no real consensus on the aggressive form of treatment here. So I'm going to continue mycophenolate till I hear back from my rheumatologist, and I take on board Prithvi's, Athol, and Murli's suggestions. Thank you.
Yeah. On to the last case or case 4.
Yeah.
Yeah.
Good evening, everyone, and the
One thing,
panelists. Thanks for the opportunity.
sorry. Just one thing, Athol, do you think this could have been a CPFE? Would this fit into a CPFE pattern?
The last case, I think the lung function profile is classic and the
Yes.
other 2 causes are not there.
Yeah.
So I have no other knowledge of any other scenario in
Because
my
of the low lung function.
that gives this
Yeah.
spectacular gap between gas transfer and volumes.
Yeah. I also thought of that actually when she had these symptoms of airway disease on presentation. But
Well,
I think
we've agreed that CPFE, of course, is not a diagnosis.
yes.
What I would be saying is that the ILD in some way is giving rise, or the immune dysregulation is giving you an element of emphysematoid destruction.
Yeah.
That's, I think, how
And she
you
had that classical straight edge sign, and then everything was looking autoimmune.
Yeah.
Bhavin, is there a lot of, I got the impression that there's some nodular opacities in the non-fibrotic areas.
No, there's nothing nodular.
Nothing there. Okay.
The scan that looked like that.
Yeah. So we'll go ahead with the final case.
Yes, please.
Yeah, okay.
Please,
Yeah, Ganesh, please go ahead.
Hello. Yeah. This is case of a 41-year-old male who is a resident of Coimbatore. He's a non-smoker and he does desk job. The background history I want to tell dyslipidemic and he's on rosuvastatin and history of atopy is there. The case detail is there was an incidental detection of bilateral multiple pulmonary nodules which was detected in 2008. To central lobular in pattern and treen bud appearances in bilateral lung parenchyma. So at that point of time till now, the patient is asymptomatic, no constitutional or no respiratory symptoms. So the patient at that point of time, it was decided to follow up after a year with a repeat scan. In 2009, the not demonstrated, and still the patient remained asymptomatic and at that point of time it was told that the investigations were inconclusive. Then coming to the next lifetime event in 2021 when he underwent a regular cardiac evaluation by undergoing CT calcium score scan in the lung window, again the pulmonary nodules were re-demonstrated which were more prominent than in the CT which was done earlier, and extensive areas of treen bud bronchiolitis were noted. With that he had come to our center in 2023. So in 2023 we evaluated for sarcoidosis for tuberculosis. In 2024 again a repeat scan was done which re-demonstrated the same number of nodules, same pattern, size and number. He remained asymptomatic, no constitutional or respiratory symptoms. In clinical examination, the saturation 97 on room air, comfortable at rest, no adventitious sounds on auscultation. And the other investigations, coming to the radiological pattern.
Yeah, we'll ask Bhavin sir to talk about radiology. You muted, sir? Not talking.
No, I'm muted. Yeah.
Yeah. Okay.
So, on the right is the 21 scan, and then on the left is the scan from 24. And then basically both of them are pretty much the same. You've got this lacy pattern of reticular opacities with some nodules, etc., which are unchanged. Right. So if we look at this appearance on the left side in the coronal plane, and then you change the window settings, what you get are these areas of ossification here. Can you see these? And then you get this dendriform pattern of lacy reticular changes. This is what we would characteristically call idiopathic uh, diffuse pulmonary ossification. And I use the term idiopathic because that's a defined condition where you don't have an etiology, but the patient's findings don't change. It's probably because of an insult in the past, and there is nothing further to be done. But this is the beauty of it. You see all these dense ossific areas and this lacy pattern here. It looks nodular, but a lot of it is just reticular opacities with these ossific areas that look nodular. So this is just beautiful. I mean, and just so that, let me just show something here where, sorry, I had actually created, can you see this?
Yes, we
I had
can.
actually done up this case in a 51-year-old, and you can see the same pattern here of disease, asymptomatic, and these were the typical findings. X-ray had shown this. But the beauty is in manipulating the images. So you look at these 20 millimeter MIPS here, and you see this beautiful pattern of this lacy dendritic ossific pattern. And when you do these coronals also, they look so beautiful. It looks like an artwork thing, and that's pretty much the diagnosis. And so if you
Why is it not microlithiasis, Bhavin?
because it's not. Microlithiasis is a
Small.
it's a genetic condition that presents with progressive disease. And microlithiasis is a septal infiltrative process where you get these peribronchovascular ossific areas. So that's different. It's an entirely different thing. So
Sure.
idiopathic DPO is also called dendriform pulmonary ossification. They're diagnosed typically at health checkup. This is the pattern. Maybe slowly progressive. A lot of this work has happened in Japan because Japan is the place for all esoteric lung conditions. I think they have a lot of time to spend on all of these things. I'm not being snarky. No, I'm not being snarky. Just that they do all of this very well. All our PPFE work, for example, is all Japanese in origin, right? I mean, that's where they look at it. They've followed up, but up to 20 years, they haven't really found anything. And then you have the DPO that occurs in the ILDs and UIP patterns, but that's just an associated condition, probably related to aspiration. Some people earlier said if you get DPO in an ILD, then it's UIP, but we can see it in any ILD as well. So that's pretty much it. So basically, our condition is an idiopathic dendriform ossification that has no relevance if the patient is asymptomatic.
DPO full form is dendritic pulmonary
So
ossification.
diffuse pulmonary ossification or dendritic pulmonary ossification,
Okay,
whichever
okay.
way you want to put it.
Sure. Yeah, Professor Wells wants to talk, please. You are
Well,
muted. Yeah.
no, I was going to say, Bhavin, if you weren't being sarky, I really want to be there when you are. I think I'd sell tickets actually.
I will share the remaining
And yes,
slide.
if the scan was a thing of beauty, clearly your summary was too. I just can't add to that, except to make the point that this pattern, when it's mixed with an ILD, tends to point towards UIP. But basically, it doesn't look like this. You get a dendriform pattern, which is UIP-like, but that's by the by. And you don't have a management other than just sitting and watching it, really. So maybe it should be managed in Japan as well.
Oh, wow, we've got a cryo. How nice. That means it should show everything.
No, it is Ganesh. Yeah.
So go ahead, Ganesh.
So we initially We had investigated for like to rule autoimmune background.
Yeah, you can
Cianca was positive, but then it was
quickly go through only
Cianca was
positive.
positive. Yeah, the Cianca was positive, but it was clinically not relevant. The other investigations, the autoimmune panel, all were negative. The patient underwent bronchoscopy to evaluate for by cryobiopsy. The cryobiopsy was done, and even an endobronchial biopsy was taken, for which it showed non-specific changes. Bronchial only fragments of bronchial mucosa were seen with lobules of mucus glands. And even in second opinion for the biopsy was obtained from the CMC Vellore, which showed no granuloma evidence of malignancy. So it was non-specific changes with mild chronic inflammation, which was reported. We had to follow the patient with a pulmonary function test over in 2023 and 2024, in which the FEs was pretty much normal. It was 82% of predicted, and in 2024 it was 80%. The DLC was mildly reduced.
Yeah, go ahead.
6-minute walk test also it was satisfactory. The question to the panelists are we had was what could be the possibilities, but we had excellent as I had told.
I hope it's all sorted, right? You have a diagnosis, you don't need VATS, and the patient doesn't need anything except maybe a follow-up every 3-4 years. That's it.
And all I would add to that is that it's interesting that it got missed on small cryobiopsy, which might have been something subpleurally. And I totally agree why subject the patient to a VATS. There isn't a differential, is there really?
Yeah.
The Ramnathan here. Do you
Yes,
have
sir.
a message for radiologists for this evaluating the nodules?
Sorry, what?
You have a message for evaluating the nodules for radiologists.
Yeah, but there are no radiologists here. So
I think Dr. Pudivan is. Dr. Pudivan is there.
Pudivan is a consultant. There are no messages. This is not a nodular disease. This is what should I say? If you've seen one, it's this. You have to be looking at the coronal planes and playing around with MIPS and MINIPS, and it's the ossific foci that give you the answer. So there's no real message. I mean, these are 1 in a decade cases, and I mean, there's no learning really from this.
Yeah.
Pick it up
He
if
is
you
an
want.
industrialist. He wanted an answer and he was waiting, contemplating, and then he came for a biopsy. And now also anyway, thanks for
Not at
your
all. Listen, I have to go, yeah. It's walking distance, but I'm sorry.
No. We will not let you go.
Carry on, Bhavin. Carry on.
Thank you so much. Thank you. Please go. Please go.
Ramnathan, is he very
honestly, Bhavin, that is brilliant. I must appreciate that.
And that presentation was also brilliant because it was almost identical case which he showed to us. Thank you.
Yeah, so take care. See you. Bye.
Thank you. Thank you, sir.
Ram, is he symptomatic, Ramnathan?
He's asymptomatic. He's absolutely asymptomatic.
Okay. But that happens in these cases, doesn't it?
In routine cardiac evaluation, CT, calcium score, they saw the same nodules. In master checkup, it is all same.
It's just another feature of this. It looks bad on the scan. The lung function impact is minor, and the impact on symptoms is often non-existent.
Right. I think, Athol, what Ramnathan's question is, the patient wants to know more, and should he be subjected to invasive procedures for that?
Absolutely not. I think you have 5 biopsy conversations, and this is a conversation where you're saying you can't have a surgical biopsy, personally. Now, look, I suppose that if you have to go to a surgical biopsy for social reasons, then just know that that is why you are doing it. But I'm completely persuaded by Bhavin's analysis, and I've seen such cases. There was a case series that got rejected from publication, so I can't tell you which center it came from. I was a reviewer. putting together a largest group of these cases and finding a minority subset that did progress. But in this case, you're not getting that signal at all. And I think you can go with the classic approach of just monitoring the situation. I don't know how you handle a patient who simply demands to have a surgical biopsy, but basically you might make a deal that you'll do that if there's evidence of anything about this that is unusual. In other words, you put the decision off and then discover that it's completely stable on monitoring.
What
my patient will agree, Ashmita, my patient will agree this diagnosis. He will be happy to get further investigation. He'll be very happy.
Sure. Thank you. No, my question was, want silicosis also, like, because in India we are seeing those quarry workers and all, and like, want it look like that, Murli Mohan sir, or anybody had seen? Because
it's not like any silicosis I've ever seen.
Okay.
Yeah. There's no lymph node involvement. Typically, you get
lymph node, calcification.
Distribution is not like that at all. I was also wondering initially about pneumoconiosis, but it doesn't really fit.
Okay.
I'm completely convinced by what Bhavin told us.
He showed the evidence by showing previous cases, so we don't have anything to say, and he was so confident. But once in a decade case, and thanks to Ramnathan sir, we were all able to see that. Thank you so much. I think we had a great cases discussion, and thank you so much. Thank you so much, all the experts and all the people who presented, took their time to be with us. Thank you.
Thank you so much.
Manish,
hugely enjoyable as usual.
Thanks to you.
And I got one on Bhavin on the Saki comment. Now that's to be valued.
That's to be validated.
I suspect I will pay a terrible price.
No way. We love that. That's what the main like that's why our meetings are more lively than any other MDM, which makes monotonous. So can we make it offline, Manish? And the next meeting will be 20th December. 20th December. We will have Vimal Raj sir after a long time. I will stick to